kind of some of those were also reviewed with Ava and Jewel through fee evaluator. So existing already in the literature are some findings from people who looked into pH algorithms, so how they performed on a clinical setting like Stanford, also across like using tools like fee evaluators and so forth. There's also another review paper that looked at kind of dissected the phenotype algorithms that exist for pH in terms of what domain of data they use, what codes they use. So looking just at the 4 last years, there is at least 3 big papers, including people who are on the call today who looked into this. So I expected that we're going to find less for pH, but we found out actually quite a lot of work for a rare disease like pH. But yet, looking at those phenotypes, I don't think anybody came close to know how to phenotype pH quite yet, which is tells us how much, how big is the gap. Okay, so thanks to, I think Butchie worked on the literature review from the people on the call here today, and I don't know, and somebody else, I forgot. But yeah, thanks for the people on the call who actually reviewed those articles. So we have identified out of the articles that we found in the literature just in the last 4 years, we have identified 12 phenotype algorithms that we replicated using Odyssey tools and ran across 7 data sources in the network. What you see here on the screen, a tool called Cohort Diagnostics. As Jamie said, it is a tool aims to help us do some evaluation on phenotype algorithm. It's not going to tell you which phenotype worked better. It's not going to tell you any quantitative data about the performing characteristics of a phenotype. All what it really does is that it takes the definition as designed, it runs it across a given data sources. In this case, we ran it across 7 data sources. Then it produced what we call summary statistics, which is technically characteristics of the people who met those definitions in the data source, in attempt to help you or to help researchers see if what you observed in terms of characteristics or trends are consistent with what you know about the disease. And we'll talk into more specific, but that's the general idea. So on the left here, you see that panel provide you with what we call diagnostics. So basically, those are reports that are produced through the app. And Jamie or Evan, if you can share the link to the Shiny with the group, in case somebody will follow along. And I see a hands up. Is that? I can't see who. Yeah, Rohan, go ahead. Hi, go.
Real quick question for you. So if I understand it correctly, for example, the manuscript that Ava and our group worked on, we looked at like 13 or 15 different algorithms. We never recommended one specific algorithm. So did you, in this process, did you then evaluate multiple different algorithms from
yeah, so very good question. You mean, did we replicate? Because we're evaluating right now.
Yeah. I'm sorry.
Yeah. So for Ava's paper, I contacted Ava. Like for your paper, I contacted Ava. I was like, this is a lot, and a lot of them overlap what we found already. Can you help? Can you direct me into kind of? And I tried to use your actual results to find that best balance, and I still couldn't find like a good direction. So what I did is I took a definition that she had kind of given the data sources we have, which is claims, some GP data sources, some 1EHR data sources, and she recommended an algorithm that kind of used the best of your findings and put them together in a way to work across different data sources, and that's what you found here as number 25, basically. All those cohorts start with 159. So this is and it might not be correct, but we were in a not correct, but it not be exactly what you would say. That's what our paper recommends, and we could do, if you have better insight of what algorithm would you kind of want to see evaluated, we can totally take that today and make sure we run it and we add it to our results. Ava was going to her vacation, and I just wanted her biggest kind of recommendation to go into the exercise, given that the paper had so many algorithms. And some of them were already, because you know how in the paper you guys listed the algorithm and referenced the paper? So some of those papers were already captured in our exercise. So those are replicated here. But I wanted, in addition to those, like where would you want me to replicate? And here is the definition I replicated, I took for Ava. And it's actually the definition that Ava, for J&J purposes, have recommended it for us. So we have a phenotype library in J&J, and that's what we use for PAH, pair the work that Ava has done. And I can work you through the.
It's fine. I think I understand.
Yeah.
I mean, I think the thing that we came, and I don't know if James had a comment or a question before me, but just quick. You know, what I realized with that project was that the algorithm choice is dependent on what the research question really is, and the requirements. See James smiling. The requirements of what kind of a sensitivity or
Yep.
specificity you want on the phenotype, and not all the algorithms were algorithms from we made up some of those algorithms based on what we've worked on prescription amphetamine work that I've done before. So some of them were from the, if you will, they were not replicated or taken from the prior publications. But
you called them proposed. Yeah, you called them proposed. Yeah. So what we did, so we have one version of that says you have to have one of those ICD-10 9 standard codes, which is the I-27.0, which is as specific as we can get for PAH using claims or using ICD-10s. And then you have to have either a right heart catheterization, and those are all the procedure codes, or a echo card that happened before the diagnosis, up to 30 days after the diagnosis.
If you show the pseudo language version in the app, it's a little more clear than looking at the UI for those that aren't familiar with it. So like if you move over to your other tab and then click it and go to the cohort definition, you can read here, like people enter with the condition occurrence of blah, and there's the concept sets are below, and then they're restricted to those with a procedure anytime up to 30 days after, and at least one procedure of, Okay.
So that is what we went basically from that paper. But yeah, if that makes sense to you. Okay. Here are the 12 definitions. I'm gonna link you all to this if ever you want to look at where those definitions come from. This sheet should give you kind of the full metadata for the papers and the definitions. Okay, that goes with this list. So let me orient you to the app very quickly. So what you see here, I'm gonna click on this one first, the counts. So what we're gonna look at, what we usually look at very quickly, is we're gonna look at the counts of the people that we captured using any of these definitions in the, I'm gonna just add this one. In all those data sources that we ran the definitions on. So here we have German data disease analyzer, which is a GP data source from Germany. We have Japan, Japan or JMDC data, which is a collection of claims plus some EHR data coming from Japan. And then we have Optum EHR, which is a US data source that is based on EHRs. We have all the market scan data sources, which comes either from commercial insurance or Medicare or Medicaid. Those three. And then we have the what we call Optum DoD data source, which is, I think, this one, sorry, Optum DoD source, which is another in commercial insurance data. So it's different data sources with different characteristics, but this is what we ran the definitions on.
And then,
and
yeah, I was just going to say, if you expand that cohort name column a little bit, we'll see the names of all of these cohorts. And it's useful to remember that when we see these numbers and the color coding, those are like absolute numbers, and they reflect they reflect how many people there are, but that's given the size of the database. So like there are far more people in Optum EHR than there are in JMDC. But you know, that we don't know what the proportions compared to the rest of the database are from this view.
Yeah. So that's not going to give you incidence or anything. That's just going to give you roughly what's the sample size you're dealing with. This is also, the count is useful because also if you're doing this as a part of the study, when you start building these phenotypes, you give an idea of what's your sample size or how much you can capture depending on the definition.
It does look like 15926 looks like it's the largest in the sources we can see here.
Yeah.
Have I understand this correctly? So can I say, like in Optum EHR, there is a tremendous variability of the number of subjects that these algorithms identify?
Yes. Absolutely correct. Not only in Optum EHR, that's across all the data sources.
Yeah, and this is what Azza was saying in the call earlier, that we're seeing like more variability, within a database across definitions than we are with one definition across databases by far.
Yeah. And that can tell you, like, you can go and if you pick the cohorts that give you the lowest number, I think it's gonna be this guy, 85 if I'm correct, just because I looked at this before. Or did 95? This guy. So if we look just at Optum EHR, I think, okay, it varies a little bit. So you have those two definitions that pick the least number. And then you have this definition that went all the way to, 165,000. And if you open this definition, you'll see that definition that picked 165,000, that's basically a super broad definition that said anybody with one code is in. While if you looked at one of those that captured 40 times less people, whether this one or this one, and open them, you'll find that one of them, particularly this one, I think 28, yeah, this one by Karen's 2020, that that required a diagnosis to occur inside a hospital, also in the primary position. And whenever you require that primary position criteria for inclusion, when you run it across data sources, it's heavy on the data. That could be because truly those things are specific or restrictive, because it's a certain number of diagnoses go in the primary position, but it also has to do with the data collection and how we assign something to be primary position for. Now, it makes so much sense for EHR data, but when it comes to claim, what is that primary diagnosis versus first position diagnosis varies, and not very clear definitions, and it could even vary in the handling of the data and the processing of the data. So we in Odyssey community always worry about that first position, because it might make sense in one health system that the way you define what a primary position or in an EHR system, but once you go into a network of data, that might mean very different thing depending on the data source, depending on the ETL process. So it's always kind of a source of noise. But generally, whenever you apply that criteria, it limits the number of people drastically, no matter what data source you use. So that usually gives us the most strict inclusion. Now, that doesn't mean it's going to give you the most PPV, but that's generally. Rohan, did you want to say something?
Exactly. That's exactly the point I was going to make, is that it doesn't improve the accuracy of that, if that's the word that we could use, or the PV, because you're restricting it to, like you said, that first. One of the other algorithms that we use, and I think you're not testing that algorithm here, is that it required the a certain time period and a certain implementation of a PAH-specific therapeutic to occur after that diagnosis. So one of the algorithms, that was really the most restrictive of one of our algorithms. Again, besides the point here, but I wonder, do any of the algorithms here that you've seen or you've implemented include the requirement of a PAH therapeutic to be applied?
Yeah, indeed, many of them do. I think 50% of those definitions, 6 of them actually requires a treatment. The one that required a treatment in the most restrictive way is this one, which is capturing the least number of people across the data sources, and it's this guy. And I'm going to open it for you. I think I have to go back. Hold on. Cohort definition. It is this one. Yeah. So this has a complicated logic, which I can explain very high level. It actually requires 2 treatments being 30 times apart. So 2 PAH therapeutics that happened, I think, within 30 days after the diagnosis. So it requires 1 diagnosis that is either inpatient or 2 diagnoses that are outpatient, followed by 2 occurrences of a therapeutic. So it's a restrictive in terms of, or it's a complicated logic. It requires 2 treatments, 2 therapeutics within a certain time frame, but it does lead to the least number of people. And you'll see that it also leads to the least incidence, which, as you expect. We don't have today the results for the specificity, sensitivity, or specificity PPV sensitivity estimates that we could get out of eValuator. But if I have to guess, this one will probably give us the highest PPV. But we don't. Let's not speculate. We'll get those by next week. Okay. So you have an idea of the variation in count. I'm going to quickly show you the variation incidence rate. This is not the best way to get incidence rate. Jamie have a better tool that gives you very precise estimates rate, but those can give you an idea of where we are. And then I'm going to give it to Evan to talk more about, like, to go to certain diagnostics. Okay, so what I'm going to do, what you're going to look at the screen right now is a tab called incidence rate. You can either look at the plot or look at the table. I will look at the plot to make a point. I will select for now all our definitions, and for just a simplicity now to select, I'm going to select Optum DOD, which is I'm selecting DOD because I'm going to look at the incidence rate without stratification of age and sex, which is something that you can get out of the app, or stratification also by calendar time. I'm just going to look at rough incidence rate, unadjusted or unstratified for age or gender or calendar time. And I just want to show you the variation in the incidence rate depending on what algorithm you pick. So again, we're limiting to 1 data source, right? No, sorry.
Why is the incidence proportion all 100%?
Because this is not real proportion. This is proportion of the biggest number here. So ignore that. Okay. Ignore that number. Because I picked all the ages and all the, so this is the proportion of the strata in the bigger.
Of the strata, I got it.
Yeah, forget that number. So what you're looking at.
But that'll change when you click these other, the strata.
Yeah.
Got it.
Yeah. So because we didn't pick any strata, we're just looking at, here are the different definition in 1 data source, and here's the number of follow-up time we have, and here are the event, and here's the estimated incidence rate for the definitions. And if I sort by now, the lowest estimate we have for that, what we call the algorithm that is strict, which is using 2 therapeutic, 2 occurrences of the code or an inpatient code, estimate the incidence on 0.02 per 1,000 year. The biggest estimate we have is for this definition that was basically any code, 1 code, and you're in, went up to 0.94. So the variation went in 1 data source from 0.02 to 0.94.
Yeah, almost
so that's
like a factor of 100.
47
50,
times.
50 or so.
Yeah,
50.
47 times. Now here's just an idea of like how much variation you see. Now, Evan and people, probably Rohan and others who know PAH, those numbers are actually overestimates of every estimate we have for the incidence of PAH in the US population and the EU population. Evan and I looked at it, and it's supposed to be 1 in a million new cases per year.
It's about
6.
it's about it's about there's
about 10, isn't it?
There's a little bit of a it's somewhere between 5 to 15 to 20 per million.
Okay. So
that's right. Of all causes, like some of those studies just look at idiopathic PAH,
that's
which will give you
right?
Yeah. So it's probably more like, I think it's like you said, overall PAH is probably like 10 to 20 per million per year.
Okay. So that's not very bad if you say 20, because that's very close to the number we get from that restrict definition. But if you only use one code, you're going over the moon or the sun with the incidence that you can be estimated. But this is the variation you see, which is roughly higher. But if it is 20 in a million, which means, even that, it's still, because that's 0.02.
You need a lot more zeros there.
We need another 0 to be correct. But that is, and I know from Eva that even, at least in our data sources, no matter what definition you use, our estimates of the occurrence of PH is much higher. Now, that could be because at the end of the day, all these are health records. You're not going to a healthy population and giving a number. Those are patients by definition. So the pool, if you might say, is either a diseased pool or a pool that has insurance, which means that they are following the health system. They're not a random pool out of a healthy population. But I'm going to stop here. I'm going to move it to Evan to go more into the tool and look at more diagnostics, just to give you an idea of what you can get here.
Yeah, I thought that was pretty interesting. Just so you guys, people who access the tool, one of the things that we actually have found a bug is that when I was trying to look at that by removing these strata, you guys see my screen now and hear me okay?
Yes.
That didn't seem to work, and so right now on the public version of the tool, we end up looking at it with these strata of age, sex, and calendar year. Just to orient you here, I haven't selected all the cohorts in part because I tried doing that and I crashed the app. So I've selected a subset of the cohorts to take a look at across a subset of the databases. And then what these plots wind up showing us is across these different age bands shown at the top, the incidence rate per 1,000 person years across the 10-year, I believe it's 10 years that I've chosen, or about 12 years. So from 2010 to 2022. I usually kind of take off 2000, the most recent year that's there, because we don't always have complete data and it can be a little bit misleading.
Sometimes nice to drop the extremes of the age groups too, because they give you very very unstable counts.
Yeah, I did. I mean, I think this one actually goes up even higher. You could make an argument that we should knock off the 90 plus group as well. And then this is then on a per database account. So here's the German disease analyzer data. We can see that some of the definitions obviously just don't work at all, like 15895. That was the one that you were mentioning, Azza, that was fairly specific. And I can't remember if it required a hospitalization code or not. But
it's either so it won't work in Germany because it's a GP data, so that won't work there. Yeah.
And then some other ones also didn't fire there. So I guess the bigger lesson here was that if you were looking at doing a network study, you'd right away have some pretty some red flags about including the German disease analyzer in that study. The other thing I thought was kind of interesting when you do look at this by age group is that there's clearly across definitions an impact from age criteria, which if you hadn't looked at this and you were just getting an estimate across all age groups about incidence, you would pick up definitions like this, where I suspect this is in that 0 to 9 age group, so probably congenital heart disease. Despite the fact that it's called pulmonary arterial hypertension, that you think you'd be getting group 1, but then things like persistent pulmonary hypertension of the newborn that might be causing some deflections here in some definitions that don't wind up restricting by age.
Yeah, because some of I suspect this definition, there was one or two definitions that their code list included the higher level ICD-10, which says like which included like congestive heart disease. Like they went too broad in their code list, and that's why they're probably picking some of these kids. And some of them did not limit to 18 and above. So that's why you're in some of these definitions you're picking some of those newborn congenital conditions.
We've seen in other conditions too that in JMDC, the coding can sometimes happen at a much higher, less specific level. So rather than a more granular code for this or that condition, a higher like level code in the hierarchy is chosen. We've seen this a lot. Was very strong in attention deficit hyperactivity disorder. Instead, what was being coded for all subtypes of that was like some sort of like very, very broad behavioral code that is an umbrella for a great number of things. But that was the only thing that was being used to pick up that condition. So like maybe that's the case among kids in Japan. I'm speculating, of course, but.
Right. One of the things I also noticed, and again, this was, these results were kind of, at least I was able to access them this morning. This is that 895 is that fairly specific definition requiring 2 PAH therapies. You see here over time, over this 2010 to 2022, kind of a slow increase in incidence, which actually is a little bit different if you look at some of the other definitions. So I mean, that in itself is pretty interesting. I'd have to dig in a little bit more as to why we'd see different effects.
So there are a few things that we always have to look at. So if you see that the second one, 15911, that definition has an issue. You see that peak and drop, that's, I'm going to guess it's 2015.
Yeah, probably.
And then, so that definition probably included a list of ICD-9 and ICD-10. Now, I worked on these definitions, so I have some prior information. There was in those literature, on those studies, there was inconsistency in the list of the ICD-9 with the list of ICD-10. What that means, if they included a more broader code in their ICD-9 list, but went more granular in their ICD-10 list, you will instantly see that drop in incidence. That just because they were not consistent in their pick. And that's also happened generally in the ICD-9 and 10 when things became more granular. So when researchers started to pick, they had more granularity to pick. But that means if they ran a study that spanned over these 2 time periods, you're going to see this drop in incidence purely due to the change in the codes. And so when you construct your phenotype, you really need to be careful, being consistent with the clinical idea of how you're going to pick the disease, not in the codes. Because if you have a study that's going to run over the 2 time span, you're going to see a noise in the change in your parameters, not due to the true change in the disease pattern, but only due to the change in the coding. So, for example, if you decide to do non-specific, I forgot what was, there was a non-specific heart disease code, you really want to do it in both systems. Doesn't matter what the code is, just the clinical idea, pick it in both. Otherwise, you'll see something like this, which is noise. And you can see it in another data source as well.
I mean, in general, I think I'd agree. Like if you look at this area of these plots, there tends to be a deflection in almost all of them. There's a couple of hands up, Jason.
Yeah, can you tell what's the definition above in the row above the 95 ending in 95?
That was that specific one that that involved the 2 PAH therapies within 30 days. I can't remember what else was on there. Let me just take a quick look.
It's two therapeutics and 2 codes
Interesting. Yeah, that one's pretty interesting to me because that that gradual rise in incidence reflects kind of with age, like higher incidence going up in the older age bands. Is reminiscent of what we see in registry studies, where of well-characterized patients were kind of between mid-2000s to like current day. We see the kind of median age in the registries of very well-characterized patients going up, and probably that's multiple reasons for that. Increased availability of echocardiograms, so you pick more people up than you would have 20 years ago. But that one does mirror sort of the trends we've seen in registries.
The other thing I'm curious about is, over this course of period of time between 2010 2022, they've actually changed the hemodynamic requirements right, for PAH diagnoses, and I don't have those dates. But you know, it made me wonder, you know, that's as they became less restrictive, which is the direction they went, you might expect a rise in incidence to be, you know, attributed to just capturing more people on that basis as well.
Can I make a quick comment? So
Yeah, please.
I think that definition is, even though even though the definition has changed, the clinical trials haven't addressed that definition. So the authorization on some of those drugs may or may not be impacted, and also practice patterns. You know, I don't know what Jason and the Canadian colleagues are doing, but what you do have to consider though is that you know, it may not impact practice patterns in like Canada or Germany or environments where some access to these drugs are much more prohibited than the United States. But you do have to account for generics that are coming onto market and having a lower threshold of diagnostic requirements to be prescribed. So, you know, obviously sildenafil, well, ERAs are now generic. Now we have prostacyclins that recently are becoming generic. So there is all these trends that, you know, the barriers to prescribe a therapy, you know, we have at least the prostacyclins in some ways and more aggressive drugs were more prohibitive in terms of what requirements the third-party pharmacy or insurers would have for a prescription of those drugs, and you can imagine that there is a change, and so you know, you have to be careful about that construct.
That's good to know.
Roham, you've just said very clearly in much detail about this condition what I was going to say very generically, and that good phenotyping requires a good understanding of patterns of care and how things change over time in terms of what drugs are available and everything, which is something I kind of expected to hear Kevin talk about, considering he wrote the paper that I reference all the time when looking at these plots.
And then the other thing, I'm sorry, is it James or Jim or?
I go by Jamie, but James is fine.
Jamie, okay, great. Yeah. Jamie, the other thing is that one of the things that we ran into in our manuscript, as separate the amphetamine work that I've done, is the prescription of phosphodiesterase inhibitors is not only for pulmonary hypertension but for erectile dysfunction. And some of the work that we tried to do doesn't capture the chronicity or the doses that are specific more for pulmonary hypertension.
So that's another like hard part of replicating those studies, because those studies that use therapeutic list the entire 4 or 5 groups of therapeutics. Then they mention that they limited, they didn't include the doses that are used for erectile dysfunction, but they don't say how they did it, because that's actually not an easy forward exercise, or what exactly. Now, in using OMAP ontology, you could do it, and I did it, but I had no idea how they did it and what that list would look like. But we could do some gymnastic where we remove a pill of 10 milligram but it definitely, and I did it very quickly and I had to improvise. But if we reach to a definition that includes therapeutics, that is one thing we would need to revise with a clinician to make sure that we didn't include any of those doses that would not be indicated for PAH. And actually, our app allows us to actually see if we have errors or not. That's a very good point, Evan.
So this is exactly that. Is that so? I had this. This is looking at index event breakdown. So just to orient you guys to what that shows us, this kind of shows us what the qualifying event was. That permitted entry into the cohort. And this is actually with that same one, that one that's actually looked like it was quite specific. And I thought this was kind of curious, right? Like this is within the German Disease Analyzer data set, so maybe not the most performant data set. Again, it's primary care, which probably affects this, but there was no real restriction on dose for sildenafil. So I suspect that I would be worried, I guess, about what we're picking up here, because this looks like probably the dose for erectile dysfunction. I also treat people with failing organ systems, so I have to double check. But that I don't know that reflects treatment of PAH.
This reminded me of a heuristic that I often use when looking through these cohort diagnostics, and I posted a picture in the chat that has a very rough approach to trying to understand qualitatively sensitivity and specificity, or what could represent sensitivity and specificity errors. And it's like if you see things that you think you shouldn't, or if you don't see things you think you should, those are probably issues with your definition that is either too sensitive or too specific. So this like heuristic picture that I put in the chat is a way that I think about looking at index event criteria and then the characterization results.
And these characterization results, actually a really good segue. So I'll move to this slide or this tab. This is where I start going through that exercise of thinking through those three main errors that we look for in cohort definitions. Again, we're not getting operating characteristics, but we can still think about them broadly as errors in sensitivity, errors in specificity, and index date misclassification. And so, exactly what Jamie said, sensitivity errors would be reflecting, you might be capturing people that you're not looking to actually capture. Specificity ones would be ones where you're actually capturing people that it's too broad. Index statement classification might suggest that the people that you're looking to phenotype might have had the diagnosis actually manifesting, before or well after the date that you've captured, or that you kind of decided to index
a good
on,
example for that one.
Index on.
A good example for that is like if you create a phenotype that is indexed on like ADHD diagnosis, and then you characterize that cohort and you see that, 15 or 20% of the people have had a methylphenidate prescription sometime in the year before the diagnosis was made, that suggests that they could probably have had ADHD at that earlier time, like before the diagnosis was there. And you can conjecture all sorts of reasons why that might be, like stigma of kids and ADHD and blah blah blah. You can make this stuff all up, but like for example, I haven't gone through these results, but are there people that have PAH treatments before the index date of definitions that are indexed at the diagnosis? Like, do we see that anywhere?
Let me see here. So
we could look right now, I suppose.
Yeah, so that's exactly it. And so what I typically do when I'm going through these results is kind of work through chronologically, across domains of diagnosis, therapy, and prognosis, and look for attributes in the health record that I expect to see. Sometimes it's actually useful to anchor on a definition that you think is really specific, because your bar of how much you expect to see, you tend to actually have to adjust that. We have to adjust our expectations of the fact that it's still observational data and there is a lot of missingness. So we don't get the prevalence that we think we should get. Typically, when I'm looking at these, I'm always just a little bit disappointed. But you have to just adjust your expectations.
You're also looking at, as you figure out this one, you're also looking as rough as it could be. We're looking at the code level. There's no grouping whatsoever here. So
Yes.
It's literally the code of a particular thing that you're looking at. And typically it's not one code that reflects an event, it's a group of codes, right, that can happen. So it's very, very granular and rough. But yeah, you can.
So this, this would be, this may not be the most specific way to look for this, because we know that this would potentially have a, other indications. But looking at this time choice here of, all time before index, you see about 7% or so within Optum-EHR have a drug era of sildenafil. So
but that drug, it's worth remembering that drug era group overlap can include the index date, because your temporal choice is from any time to before the index. So like that 7% of people with a sildenafil exposure, it could be on the actual index date. So what you could do is, there is a time window selection, I think, so that your temporal choices can actually, there you go. You do like a year to 1 day type thing. And
yeah, so you typically take the 0 to 0, to see the exact overlap. Then you do 1 to 30. That's things you do want to see. And for index event misclassification, you look at the minus. Yeah, you can look. Yeah.
Minus 365 to 31, and then 31 to 1.
Yep. Exactly.
30 to 1. There
Yes.
we go. Let's see if we can generate that.
So it is interesting to look at therapeutics for this particular definition because Ava here did not include therapeutics in her design. So you want to see if you don't require therapeutic, if this definition has a good PPV, you expect that to see therapeutics, right? Because if you're truly capturing true patients, and you want to see them after index, of course.
And we are seeing it after index at about 1.4%, but we're also seeing it before index at the same exact same number, which is peculiar.
That that might be that overlap for erectile dysfunction we were talking about. And then so if you choose a much more selective PAH drug like epoprostenol, you would probably not see that. Or Flolan, I don't know how it would be termed here, but
did I spell it wrong?
Well, no, look in your analysis name. You probably don't have drug exposure checked. You might just have the in this one. If you find drug exposure, there you go. The drug exposure will be the most granular. It'll be like an RX norm level rather than a. It's like,
I'm only seeing device exposure.
Oh, I thought it was up there. Oh, I guess by default it doesn't do it. Okay, drug era start and drug era overlap are the ones then. My bad.
You might want to try Flolan. I don't know why EPO. No.
You try one of the ERAs because they're more specific, like Bosentan.
Yeah,
that's been around long.
Like Bosentan.
Yeah.
Bosentan, try that. That's been around the longest. And
does it share an indication with erectile dysfunction?
No, that's what's nice about it is it's much more specific.
Great.
Yeah.
No, so we're not picking up much here. I don't know if there's something that I'm missing.
Let's see what you've got. Can you go again on the analysis name?
Did I check that one off again?
No, I think you'll find drug data. Can you go look at the domain again? Oh no, you do have drugs.
And remember, we're also looking at Optum EHR, the electronic health record. Like we might see something that we are expecting in the claims databases as well.
But the Optum EHR have good coverage of the drugs actually.
Yeah.
And I've got CCAE here too.
Oh,
so
I see.
Look into.
Oh, I see.
Evan, can you just in the filtering, can you keep things as is? As long as you have drug era, I think. Yeah. And then remove the filter and then just go and let's just pick the, let's see. Analysis name, remove. Can you filter on the analysis? No, if you.
I think you need to regenerate the table once you've made choices up there as well.
Yeah.
Once you've made changes.
Okay. And then filter on drug. Okay, you want to try this first.
Oh, filter on
here we go.
Drug?
Yeah.
So we do have drug errors here.
Yeah, and then do ascending, Yeah, you're not I see. Something is wrong with the Optum EHR. You're not capturing the disease. You're not capturing drugs.
Yeah.
Oh well, there's some over here. And then maybe sort it now by mean. And I guess you have okay.
Well, we'll have to take a look at that. I mean, the other thing I thought was kind of interesting here was, given that we're looking for people with group 1, some things I was toying around with was things like the occurrence of heart failure If we think we actually do have group 1s, and these might be people who were manifesting right heart failure. And so, if we were interested in trying to find, the time at which they actually started to manifest clinically, we could have an example here of index date misclassification where, if we had some kind of use case that we really want to be picking up people that, when they first, presented with symptoms, then you might make the argument that despite the fact it's labeled as systolic heart failure, that they were probably showing up with right heart failure. Or you could also take a look at it as a concern that you might have a specificity error where we might actually have people with group 2 PH who are kind of making their way into the definition. But look, I know we're at a minute before time. So this, the goal here was to kind of at least start the walkthrough, not to necessarily come to some consensus. My sense on some next steps, I'd love to see, and I'm happy to take this on, some more of the definitions that were in Eva's paper laid out here as a prelude to potentially looking at how one of them might work for looking at the study that Rohan had mentioned around amphetamine use to see if we have one there that we think is the best fit across the data sources that we have. So that would be one next step. The second one was I was kind of curious to probe some thoughts from Rohan, Jason, and others. Was when we first got into this, like as I said, I was surprised at how it seems like it was almost saturated. There was so much work that was been done. That's one way to think of it, as it being saturated. The other way to think of it is that it's got quite a large appetite because it's a rare disease, and this is one of the best, the only ways we have to study it. So whether or not we thought there was a descriptive paper or something in here, once we have a few more of these done, if we think there's an appetite within the PAH community to see something written up along these lines, so that people can take a look at these definitions across a network of database, we can certainly keep, have an asset like this available that we make available to that community. Jason, I see you got your hand up.
Yeah, I mean, to me, like the variability in itself is an interesting story. Like the heterogeneity across different data sets, I think, is really interesting. That I don't think has been looked at. And the other application for this I find really interesting is other drugs of interest that we haven't established a link between PH. So there's a couple of different approaches that are used epidemiologically to establish relationships between drug prescriptions and onset of PAH. And the amphetamine story Rohan has largely led. There's a couple of other drugs of interest that I think we could explore if you have reliable drug dispensation data in these data sets. For instance, like the myeloma drugs, like these proteasome inhibitors. There's a increasing literature coming out about them, and with the size of the cohorts that you have here, we could explore some of those relationships like at the next level. So I think there's some like pharmacovigilance stuff we could do as well. This has kind of already been looked at.
Sorry, Jason, I didn't mean to cut you off. Yeah, what Jason is saying is really impressive to me, and we had this drug-induced pulmonary hypertension symposium last year at Stanford, and Jason was there and a couple of other colleagues. And the thing that we really didn't get to was developing a tool that would eventually be sort of out in the wild or a live tool that colleagues can utilize overlapping whatever data sets to give a heads up to clinicians about the potential risks of rare disease pulmonary hypertension occurring in the new therapeutics environment. I'm really astonished. I was on general pulmonary service last week, and there is this oncological drug for ovarian cancer that causes 10% of patients who receive the drug develop lung pneumonitis. Not pulmonary vascular, but no one is watching the shop on this. And I had 2 women that were admitted to my service with severe lung pneumonitis, and no one is watching out. So I think the same paradigm might be true in terms of not only discovering new agents, but also giving a heads up to the community about agents that may have the potential for harm as they're coming out in terrible diseases, cancers, and others, as Jason pointed out, but causing another rare, terrible side effect.
Well, interesting. I mean, I think if there's an appetite, we'll definitely look to collaborate and maybe put something out that, presuming that it's a kind of the appropriate tool for looking at those types of things. There are some other ways we can look at, incidents that we'd have to, think about. But I think it's a nice exploratory tool, and certainly in terms of looking at heterogeneity across definitions and across databases, this would be the tool that people can use to evaluate that.
Oh, sorry. Go ahead, Aza. Go ahead.
I would just add that whether if there is an interest in clinically important question to answer related to treatment that people with PH get exposed to and how and what certain type of outcome they might get out of it. In OHDSI as a community, we have multiple standardized tools that can do this across the network pretty efficiently and using like standardized methods. And Evan, you will have to think of like whether there's an SOS challenge or maybe a network study on the side that you could manage. But from the community, these are questions that we can answer consistently and quite efficiently with the right data partners.
Thanks.
I have one additional thought and something I'm trying to work on in our own region, but with a small population of people. If you can answer this with these OHDSI networks, is looking at the complications of pulmonary hypertension, like Evan alluded to. Like, can you look at rates of heart failure admissions, because presumably they're right heart failure. And one of the things, like Rohan and I are working on a trial for right heart failure, and we don't really have, there's actually no population level epidemiologic studies of right heart failure out there. There's only descriptions within other certain disease states that are at risk of developing right heart failure. So we don't have any real sense of population level incidence prevalence at all. And that's really important for us in developing trials, because we don't know how frequent this is. So how do we plan the number of sites we're going to need, for instance? So that's like sort of a, if you can establish incidence prevalence of pulmonary hypertension, then you can establish the corollary is that you can establish the incidence prevalence of the complications of it, other than just mortality. So you could use broad definitions of heart failure. There's also ICD codes for like isolated right heart failure, acute heart failure, cor pulmonale. There's various different permutations of ICD codes that we could look at. This is something I'm trying to do locally, but I'm working with a population of only 4.5 million people. If you can, as like the denominator, if you could look at this in your data sets, it's much more powerful.
We certainly can. And the other thing that actually we didn't mention, but that can really enhance even just kind of the experience in this type of tooling is, as you guys can see, like there's, we have what we call our feature extractor output that, or a limited set of that feature extractor output that populates this tool right now, but you can create cohort definitions that kind of glue some of these concepts together to something that's a little bit more clinically coherent. So, to your point, Jason, there could be one that looks at a broad definition of heart failure, a more narrow definition of right heart failure, and then you'll get some of the, that'll bring up some of these concepts into one coherent group, and you'll see, a mean incidence across, that's a bit more of a meaningful number, and not kind of atomized into all these different concepts that might represent the same clinical idea. Kevin.
Yeah, so just really quickly, while we were talking, I ran the numbers of epoprostenol, which obviously is an injectable, which is obviously administered in hospital. Claims data, as expected, is not going to capture this well. So let's just not oversell these resources. Even though you might have 26 million, 36 million, 180 million people, you're kind of like looking for your keys under not the light post, right? Your clinical data is real rich, but you're not going to have that hospital data. So for example, in CCAE, there are only 1,250 people on epoprostenol at all in the entire database. That is regardless of indication and any other types of specifications like 1-year lookbacks and all that other stuff. In DOD, it's 1,300. Now in Optum EHR, it is 15,000, which is nice. But again, you might not have all of that extra clinical information if they seek care, not 100% at Optum EHR facilities. When they get picked up by the ambulance, they go, I'm in that observational prospective observational study. You have to take me back to this healthcare organization because there's a guy named Jamie Weaver who's sitting somewhere waiting for my data. So we have to just temper our expectations a little bit on the completeness of the data resources.
And just remember, those are J&J data sources. This is not the entire community, and the community has different data partners with different type of data sources. So this is just, we're looking here at our internal data sources, which are only mainly claims, with all the limitations that claims data has.
I think Rohan.
Just that one quick, just going back, let me know. I'm quite interested in this relationship between amphetamines and the occurrence of pulmonary hypertension, and I would love to see how I could think of our group as this group as sort of looking at that question, whenever the time is right, I'm glad to present some of the preliminary data that we've done along with Ava. Not as comprehensive as what I think we could do within this initiative, but I just wanted to put a pin in that for the group.
100%. Very interested. Great. Well, I know we've run over, so I apologize for people who might be neglecting their next commitments, but I think I've got some ideas around next steps in terms of things we can do to flesh out a few more cohort definitions, some of which that would be relevant to, I think, that use case that you mentioned, Roham, around a network study, choosing one for a forthcoming network study, and maybe I'll chat with a few of you guys around what kind of angle we'd take on a write-up of this, and if the PAH community would find it useful, then it should be out there.
Yep.
Great.
Awesome.
Well, thank you guys so much. It was a really engaging call. I learned a lot, and thanks, Asa, Jamie, and others for carrying the torch on this whole Phenotype February thing that leads to conversations like this.
I feel like we've got through a tricky part, but the hard part is going to be synthesizing all of this into a coherent, word limited document that will go out to the world.
Yeah.
So we've got our time to write a long letter, but then have to make it shorter.
Yeah.
Great.
Thank you
all.
Really exciting stuff. Very cool.
Okay.
Thank
All right.
you.
Nice
Bye.
Bye-bye.
Nice to hear you, Jason. Bye, guys.
Bye bye. Bye. Thank you.